Hello, my name is Dr. Naila Siddiqui Kamal. Welcome to the medret TeleOBGYN virtual course lecture series. This lecture is part 2 of first trimester complications. Here I'm going to address embryonic demise, ectopic pregnancy, and molar pregnancy. An early miscarriage is the loss of pregnancy less than 13 weeks gestation, also known as first trimester miscarriage. About 1 in 4 pregnancies where a woman has missed a menstrual period and has a positive pregnancy test ends in early miscarriage. In situations where the woman may not even know that a miscarriage has happened, often is called as chemical pregnancies. A chemical pregnancy, also called as a biochemical pregnancy, is very early pregnancy loss, which usually happens just after the embryo implants, before or around 5 weeks. Early miscarriage is usually diagnosed by pelvic ultrasound after a woman has experienced vaginal bleeding or abdominal pain, or has had a routine 12 weeks booking ultrasound scan. Miscarriages are defined as complete miscarriage, threatened miscarriage, incomplete miscarriage, inevitable miscarriage, recurrent miscarriage, or septic miscarriage. Usually, the term abortion is more used in textbooks and literature from the United States of America, while as the European texts use the word miscarriage. The diagnosis of early embryonic demise is made using the crown rump length, or the CRL, and the mean gestational sac, or MGS, measurements on the ultrasound. Here are some measurements and guidance as to what to do when the cutoff of these measurements for CRL and MGS are present in order to manage the miscarriage. The clinical diagnosis of threatened abortion or miscarriage is presumed when bloody vaginal discharge or bleeding appears through the closed cervical os during the first 20 weeks. Bleeding in early pregnancy must be differentiated from implantation bleeding, which some women have at the time of expected menses. Management of threatened miscarriage is usually conservative, and acetaminophen-based analgesia may help relieve discomfort from cramping. If uterine evacuation is not indicated, bed rest is often recommended. However, it is to be recognized that this is not going to improve outcomes. Depending on the amount of bleeding and progression to inevitable or incomplete miscarriage, medical or surgical management will be decided. The guidance on NTD prophylaxis should be considered as described further on in the lecture. Inevitable miscarriage is the gross rupture of membranes occurring in the first trimester along with cervical dilatation, and nearly always this is followed by either uterine contractions and a gush of vaginal fluid during the first half of pregnancy. After 48 hours, if no additional amniotic fluid has escaped and if there is no bleeding, cramping, or fever, then a woman may resume activity and pelvic rest. With bleeding, cramping, or fever, the miscarriage is considered to be inevitable, and the uterus then is evacuated according to the situation. Incomplete miscarriage is when bleeding that follows partial or complete placental separation and dilatation of cervical os. The fetus and the placenta may remain entirely within the uterus or partially extrude through the dilated os. Before 10 weeks, they are frequently expelled together, but later on they may deliver separately. The management options of incomplete abortion include surgical curettage, medically inducing the evacuation of the retained products of conception, or expectant management in clinically stable women. With surgical therapy, additional cervical dilatation may be necessary before suction curettage. In others, retained placental tissue simply lies loosely within the cervical canal and may easily be extracted. There may be a situation where the woman might get a vasovagal syncope because of the parasympathetic nerve supply being stimulated by cervical dilatation and causing bradycardia. In such cases, if the tissue is seen sitting in the cervix with a sponge holder, they should be evacuated. There is a huge role for the manual vacuum aspiration, which is considered to be the preferred method by WHO, is a safe and effective alternative method for surgical management of miscarriage. It can be done in the outpatient setting under local anesthesia. It reduces patients' waiting time for surgery, cost of hospital stay, and avoids general anesthesia related complications. And it has a huge patient choice preferability. Complication rates are similar to those of electric vacuum aspiration carried out under general anesthesia in an operating theatre. The necessary skills are quite easy to acquire, and minimum additional training is required. There is an MVA syringe which is made up of latex-free plastic, and it can be either a single valved or double valved syringe, and it has a volume of 60 mils and can create a vacuum of 610 to 660 mmHg. This is similar to the vacuum that is generated by an electric vacuum machine. Cannula are 24 centimeters and are color coded according to their diameter, which ranges from 4 millimeters to 12 millimeters. The size of the cannula is chosen according to the period of gestation and the estimated size of the uterus. It has graduations with 6 marking dots starting at 6 centimeters from the tip and spaced 1 centimeter apart. The tube is flexible and the tips are rounded to help minimize the risk of uterine perforation. The MVA procedure can be performed in the outpatient setting, for example in a treatment room in an early pregnancy assessment unit. Written consent should be obtained from the woman. Cervical preparation with synthetic prostaglandin E1, which is misoprostol, 2 to 3 hours prior to the procedure is mostly used for termination of pregnancy or missed miscarriage, especially in women where there is a tight cervix. Some operators prefer to dilate the cervix by starting with a smaller cannula and increasing the diameter until it is possible to insert the required sized cannula. Misoprostol 400 micrograms can be taken by the woman sublingually, orally or vaginally 2 to 3 hours prior to the procedure. This makes the cervix softer, easier to dilate with the plastic Carmen cannula, thereby avoiding the use of a metal dilator, which may make the procedure less painful. For preemptive pain relief, 500 milligrams naproxen or 400 to 800 milligrams ibuprofen can be given orally 1 hour before the procedure. In women with contraindications to NSAIDs, paracetamol or codeine based analgesics can be used. Baseline observations of pulse, temperature and blood pressure are taken on admission. Patient is asked to empty her bladder just before the procedure. Vaginal examination is performed after cleaning and draping, and the woman is put in the lithotomy position. The size and the position of the uterus and cervix are assessed. MVA syringe is charged, that is, the vacuum is created by pressing the distal valves of the syringe until they click into the locking position. The plunger is then pulled backwards to generate a vacuum. Cusco speculum is inserted to visualize and infiltrate the cervix with a local anesthetic. Lidocaine hydrochloride 2% anesthetic gel may be applied topically to the cervix, followed by paracervical injection of local anesthetic, and this is usually 30 milligram per mil prilocaine and 0.03 international unit per mil philipressin into the 4 quadrants using a dental needle. The intrauterine contents will start being aspirated via the cannula into the syringe. This can be done a few times until the cavity is totally empty. If a patient comes bleeding quite heavily, IV access should be secured. Intravenous fluids as well as oxygen, atropine, oxytocin, etc. should be available just in case if the patient needs more aggressive resuscitation. Important to carefully select women who are at low risk in order to use the MVA method of management of miscarriage. The selection criteria generally is that the woman should be hemodynamically stable, Paris women, well motivated. A nulliparous woman can also be attempted on. Ultrasound diagnosis of early fetal demise with the crown rump length less than 25 millimeters. Ultrasound diagnosis of incomplete miscarriage with retained products of conception less than 5 centimeters. When there is no clinical signs of infection. Women who are not suitable for MVA include when the gestation is more than 10 weeks period of gestation, they have a history of panic attacks, or there is cervical stenosis, or there is a fibroid uterus which has got more than 10 weeks size, or there are uterine malformations, hemorrhagic disorders, allergies to local anesthetic, or in cases of postnatal retained products. Obviously, in infection and inability to tolerate pelvic examination or retain products more than 5 centimeters, this is not an appropriate method. Complete miscarriage is the expulsion of entire pregnancy which may be completed before a woman presents to the hospital. Usually the history is quite helpful when they give a history of heavy bleeding with cramps and passage of tissue which has got fetal tissue in there as well, or products of conception. Os will usually close after the uterine cavity is empty. In cases where gestational sac is not identified, an ultrasound can be done, and if an empty uterine cavity is found upon patient's presentation, obviously the pregnancy test will still be positive. Then there is a question mark of where was the pregnancy. Is this a complete miscarriage, or is there a chance of ectopic pregnancy or pregnancy of unknown location? In such cases, serial beta HCG is quite helpful. The expectant medical and surgical management, which is done usually for missed miscarriages and incomplete miscarriages, is described in the slides. Following a diagnosis of missed miscarriage or incomplete miscarriage, expectant management is offered as a first-line management strategy provided the patient is suitable for this. According to NICE guidelines, 7 to 14 days can be given to await events to take place on their own, while as ACOG guidelines suggest awaiting up to 8 weeks. Medical management is with misoprostol alone, which is a prostaglandin analog, administered vaginally, orally, sublingually, or rectally as a single dose or divided doses. There is an option of using an antiprogesterone or a mifepristone prior to misoprostol to potentiate its effect. Surgical management includes suction curettage under general anesthesia. As we have discussed already, manual evacuation aspiration can be offered as well for suitable cases. The doses of misoprostol, according to NICE and ACOG, are 800 microgram given vaginally for missed miscarriage and about 600 to 800 for incomplete miscarriage. ACOG advises administration of 200 mg oral mifepristone if available 24 hours before giving the misoprostol. Surgical management includes uterine evacuation with surgical suction curettage, or as we mentioned, manual evacuation aspiration. Complications of any interventional management include bleeding, infection, uterine